Good morning, everyone, and welcome to Tyro Multidisciplinary Seminars. It is a pleasure to have you join us this morning, and I will promise you at the very outset that this will be an extremely informative and very unique program that will be worth listening to now and probably listening to again over time. I have the extreme pleasure of introducing our panelists this morning. I can't do them justice because of the time constraints, but I'd like to start with my colleague at Mount Sinai, Dr. Margaret Brandwein-Weber, Dr. Yuri Nikiforov, who is professor of pathology and director of molecular anatomic pathology at the University of Pittsburgh. We are joined this morning by Peter Sadow, who is director of head and neck pathology at Massachusetts General Hospital. Zubair Baloch, professor of path and laboratory medicine at Hospital of University of Pennsylvania. Dr. Eyal Robenshtok, who is a frequent flyer on this program and joins us from Israel. He is endocrinologist and thyroid cancer specialist at Rabin Medical Center and head of the thyroid cancer service at the Davidoff Cancer Center. We have three colleagues this morning, all of whom have presented frequently on this forum. Dr. Mike Tuttle, who I'm not going to introduce, Dr. Ashok Shaha, who also I won't introduce, and Ronnie Ghossein, director of head and neck pathology at Sloan Kettering. This threesome is fondly referred to as the Memorial Thyroid Mafia. And so with that, let me just get into why we're here this morning. We're talking about the thyroid cancer patient journey. And this is my attempt to portray what the old journey used to look like. And this has gotten significantly more complicated. And this is what the new journey looks like. And so what we are really going to focus on is those items at the bottom that are highlighted in red, and talk about the central role that cytologists and pathologists play for all of the clinicians who are in the outer circle, the surgeons, endocrinologists, medical oncologists, nuclear medicine specialists, and individuals who sit around a table at thyroid tumor board and constantly ask our cytology and pathology experts for insights to help us to answer the following fundamental questions. And they are, what is the risk that this nodule is cancer? And what is the likelihood this nodule is a more aggressive cancer? And the next is, what is the risk that this patient will die from the cancer that has been removed? Is this cancer low, intermediate, or high risk to recur? And what's the likelihood that it will respond to radioactive iodine? And the forum for this morning, I have asked, and along with my clinical colleagues, for each of the pathologists to answer this question. We want to know what the single case is that taught you the most about thyroid pathology in your career, and to highlight why this is important for clinicians to understand that. And at the very end, I've got three questions that we are going to ask our colleagues in pathology to address that we feel are important for patient care. We welcome, as always, your questions and comments from the audience. I'm going to do my very best to get to those. And so we're going to start off with Dr. Baloch. Zubair, take it away here.
Okay, thank you, Mark, for inviting me. And I feel totally overwhelmed by all this expertise around here. So the question was asked that we should present a case that we learned a lot from. And you know, it's interesting because it's an everyday process, especially for us and hopefully for all of us. But this case was something which really brought back the multidisciplinary approach to thyroid nodule management and thyroid cancer management, or thyroid neoplasm management. Plus, it brought up this whole venues in it. It kind of shattered some of the things that I used to think about and probably have to rethink about this. So can I have the next slide? Next slide. So this is a very recent case. It is a 50-year-old euthyroid man with a slowly growing left neck mass. I try to go into his chart and try to figure out how long it has been there. It's basically has been there for a pretty long time, almost over a course of a year or before that. His initial ultrasound evaluation showed this to be a spongiform mass with similar echogenicity to the thyroid gland, and thyroid also had this spongiform multinodular cystic mass. Can I have the next slide, please? I'm not an ultrasound expert, but on the left of my screen, you can see this mass, which has a very spongiform appearance, which really, if it's in the thyroid, it's always related to being a benign type of appearance. And this is on the right is the left thyroid. So at this point, there were multiple findings, ultrasound findings, and it was favored this most likely, this patient has a multinodular goiter, and this may be either a parasitic thyroid nodule in the lateral neck or in lymph node, but this is still considered to be an atypical finding. Can I have the next slide, please? So this is the FNA of that lateral neck mass. It is basically, you can see, these are some of the best fields. The follicular cells in there, which are in the middle, are very dark and small. There are no nuclear features to suggest this is a papillary carcinoma. They do look like follicular cells. And then in the background, there is a lot of that bluish changes is watery colloid. And when the cytopathologist sees that on site, they always think that this looks more like if this was a thyroid, it would be Bethesda 2, or this looks benign. So, but there is no lymphoid tissue. This was all this, every single slide showed this, and multiple slides were prepared. So we took this case to the multidisciplinary thyroid conference because this is definitely a lateral neck mass. This was the radiologist and endocrinologist favored at this point, but they still were worried about it. Can I hit, yeah. And the pathology was that there are multiple nodules. Yes, it looks radiologically benign, but in the lateral neck, having so much of an ectopic thyroid tissue is kind of, at least I have not seen it. And so was Dr. Lewis. He was like, I have not seen that much of an ectopic. So, guys, be careful. And we know in pathology, sometimes when the lymph node is entirely replaced, it can have this macrofollicular appearance in some of the tumor metastasis. And the surgeon said, we have to wait for the final word because I have to go in and take this out. And this is going to be a massive surgery to be done. So next, so the idea came in, can we perform molecular assay? Now, granted, this was a lateral neck mass. We did not collect for molecular pathology. So we said that, can we do something else? And can we hit return? However, we have worked with Yuri, who's on this call, and where we have validated that you can do, which other companies also do, that you can use the smears. If you have enough cellularity, you can scrape those cells off and do a molecular assay. So we did the molecular assay. Can I have the next slide? And the molecular assay showed that this was an ETV6 NTRK3 fusion in this sample, which is associated with fusion-associated thyroid carcinomas, especially papillary thyroid carcinomas. And Yuri also told us, and which is what was very learning experience for me, that he has seen cases in which these tumors have macrofollicular, that means large follicles, a lot of watery colloid in them, and they can actually be mistaken for benign thyroid nodules. We know when we see this on the surgical pathology slides, having those follicles does not mean it's not cancer if you do not have nuclear features of papillary carcinoma. But for me, this was a very learning experience, regardless whether the ectopic thyroid tissue exists in the lateral neck, the amount and the burden of the disease, and cytologic interpretation and molecular findings to help us out. Can you hit return on that, Mark? So this was the patient underwent massive lateral neck lymph node dissection, central, and they took out both lobes of a thyroid. This is the left lobe at the bottom, and it's all sliced out. And as you can see how this mass is so spongiform, and it actually looks like a goitrous nodule, even on the gross examination. But if you look in the middle, there are some solid areas in it. Can I have the next slide? So I did go into literature and looked at, and Peter is on the call, who has really published on this also, and Yuri. And you can see these are the lymph nodes. And it's like massive macrofollicular growth with a colloid in it, totally replacing the lymph node. Next slide, please. And this is the thyroid. So this is one of those solid areas, which is papillary thyroid carcinoma. It has follicle formation. So it is that has this macro and solid growth pattern in these areas. Can we hit return again? And this is the larger follicles within the mass. On the left side, you can see that hole with a little bluish tinge to it. Darker, those are samoma bodies. There was multiple samoma bodies and viable tumor emboli, some even with macrofollicular appearance throughout that left lobe. But the disease was in the left lobe. The right lobe was actually okay. But there was also these multiple small foci of papillary thyroid carcinoma. Can we hit the next slide? So I think this one really made me realize that how this molecular analysis, and especially this multidisciplinary approach, where if you take everything in silo before the molecular still hit, it's really, we can be very confusing with a benign process. Plus the presentation of these tumors, which are fusion-associated carcinomas, we know some of them can be they are multifocal, and some of them can be very aggressive tumors. Their presentation, for me, this was a very learning experience. And it also made me think about the things that we have struggled with, like even a small amount of thyroid tissue in a lymph node in the lateral neck. And I was always told by Dr. Lovelsi, never call this ectopic unless you're 1000% sure, because you can see this in the central neck sometimes. So what does this mean? Can I have the next slide, please? So for me, this really very quickly to show you that how this molecular assay combined with the ultrasound findings, the clinical presentation, this was a case which came back positive as we called it suspicious for papillary carcinoma. It had NRAS mutation, and based upon that, just that single mutation, the patient only had lobectomy, and it turned out to be a NIPT-P. Can you hit return again, Mark? So this was the case that I call follicular neoplasm. It came back with RAS and TRK promoter mutation, and the patient underwent total thyroidectomy, plus the lymph node sampling because of the TRK promoter mutations. And can you hit return again? Enter, please. And as you see in the bottom, the main tumor mass was a follicular variant, but it did have foci of 40 differentiated carcinoma. And the bottom, you see this tumor have necrotic areas within it. So I think it's at this, even though the molecular may not be available to all, I think it really, for me, has been a learning experience, and also what kind of surgery patient gets. So I think that multidisciplinary approach, can you hit enter, please? So what I have learned, and the big proponent that everything in silo really doesn't matter, because you get cocooned into your thinking so much that you just stay kind of, which is not a bad thing. We have done it for a long time. But I think the present is that you have to take everything in account before even issuing a diagnosis and further management of this patient. Can you hit enter again, please? So this is my version of how this management works. And I think all this matters, and all this information really help us guide from cytologic interpretation, which nodule is biopsy, cytologic interpretation, and if you have access to the molecular test, really guides how these patients are managed. And I think it's very much reflective of what we see in surgical pathology. So for me, this was a very learning case from a point of view of it really emphasizes this personalized approach to thyroid nodule management and even cancer management. Plus the role of pathology, which is kind of tweaked when you have this information available to provide really the best possible diagnosis for management, not because I know too much than everybody else. So thank you so much. That will be my last slide.
Terrific. So let me reach out to our clinicians here. Ashok, you're presented with a patient who's got a growth in the lateral compartment, and the biopsy comes back as benign thyroid tissue. Where do we go with that? are we obligated with this in the rearview mirror here? Are we obligated to remove that, even if there's no signs of malignancy?
It is not uncommon when you have a lateral neck mass that the biopsy is either benign or atypical. You need to go back to a few things. Look at the thyroid. Is there a lesion in the thyroid? If there is a distinct lesion in the thyroid, you can biopsy that and you will get the diagnosis. The old, the good old term that we used to use, lateral aberrant thyroid, that has been probably denied in the surgical and pathology world. It is rarely a benign thyroid tissue. It is invariably a metastatic low-grade papillary carcinoma. The question is, do we need to jump in right away, or could we monitor the patient? Knowing that this pathology has been there for a number of years, I don't think you will lose anything by monitoring and seeing that there is a growth and then undertake appropriate intervention. Clearly, the molecular pathology is of great help, but to me, it is always metastatic thyroid cancer unless proved otherwise. What to do about it? Do you want to do total thyroidectomy or lobectomy and neck dissection? That's a matter of judgment and philosophy of the institution, individual. Amongst all the things that Zubair showed, one other thing needs to be added, and that is the patient factor. What does the patient want? Sometimes the patient wants the diagnosis today and cure of the disease today. And those are the patients where I would jump in and do everything that is possible. Patients know more about thyroid disease than we do today. They are well prepared. So be prepared to answer them. It is never a consultation today in thyroid. It is invariably a confrontation.
Zubair, final word here. Do we need molecular testing if our evaluation of the thyroid is negative for malignancy, but we've got this lateral neck mass? Do we go directly to molecular testing from this morning onward here?
No, I think if you have a thyroid nodule, if we take away that lateral neck mass out of the equation, if you have a thyroid nodule and there is a benign diagnosis on it, I don't think those samples should be submitted for molecular analysis. Otherwise, you will have thousands, everything you will be sending for molecular. This case presentation was, remember, this was not a single mass. There were multiple masses. And Dr. Shaha, the molecular analysis was done because the patient insisted that this is a benign diagnosis and this has been there, I'm not going to do anything about it. So we had to really prove to the patient that this is abnormal, because from everything else, even if it looked spongiform, benign cells, multiple nodules, it does not compute with the presentation. So this is how we pushed it to really go forward, because we don't submit every single smear to send it for molecular. So I think in this case, but if to answer the question, if that scenario comes back again to me, I will push for molecular, because to me that I will, for the patient's sake, then tell them, yes, you do have cancer. Because the patient was, there's a benign diagnosis. I had this for a year or so, I don't care. So, I think that's where it helped. I hope I answered the question.
Terrific. Dr. Ghossein, take us away here.
Okay, so while the case that Zubair, Dr. Baloch showed is a modern case, my case is really from the ancient past. This is a case I found in a retrospective study, but it really illustrates the evolution of the thinking of pathologists in thyroid carcinoma and maybe of clinicians. So this was a 51-year-old man with a 3.2 centimeter thyroid mass found on physical exam. I don't know if they used ultrasound at Memorial in 1985. I was not there. Mark Tuttle was not there, and even Dr. Shaha was not there. And so they went ahead and they did a lobectomy. Next slide. So the lobectomy showed a encapsulated follicular lesion, for those who are not pathologists, making follicles, basically, with absolutely no invasion, no capsular and vascular invasion. And then you have on high power the nuclear features of the papillary carcinoma family of tumor, enlarged, clear, irregular, overlapping nuclei. Next one, please. So at that time, as I said, I was not there. It was called by one of my predecessor, probably deceased now, follicular carcinoma with capsule invasion. I have no idea why, because I did not see capsule invasion. That is interesting, shows inter-observer variability. And if I had seen this case between in the 90s until 2016 for a period of 26, 30 years, this would have been called by all of the pathologists here on the panel, I'm practically sure, encapsulated papillary thyroid carcinoma, follicular variant, non-invasive, and in many institutions, maybe a completion lobectomy would have been done. Next slide, please. Well, no completion thyroidectomy was done, no radioactive iodine therapy obviously was given, and I have wonderful news. The patient is doing well, alive with nothing. No recurrence after 27 years. Next one, please. So this kind of cases prompted me in 2006 to do this study on follicular variant of papillary carcinoma with many of my colleagues at Memorial, including Dr. Tuttle and Shaha. Next one. And I won't go into the details, but basically, to make it short, it showed that you have really two types of follicular variant: infiltrative tumor, which can have a good amount of lymph node metastasis, as you can see here, like classical papillary carcinoma, and encapsulated follicular variant, which are a completely different animal. When they have invasion, sometimes you see lymph node metastasis. When there is no invasion, there are absolutely no lymph node metastasis. Next one, please. And actually, we even had cases, 31 cases of encapsulated follicular variant without invasion with a decent follow-up, treated by lobectomy alone, with a median follow-up, not a mean, of 11 years. And nothing happens to these individuals. Next one, please. I have to tell you that when I did this paper before, I also was prompted by nascent data in molecular pathology showing that the molecular profile of the follicular variant is very close to follicular adenoma and carcinoma. It was Yuri Nikiforov on this call who did the first paper in 2003, and what shows that we have 40% RAS mutation is in approximately in encapsulate in follicular variant in general. We at Memorial did also a study using comparative genomic hybridization that shows similarities. Tom Giordano and Yuri Nikiforov did a study on expression arrays, showing the similar. Next one. Actually, we at Memorial, with Jim Fagan, the chief of endocrinology at that time, we did a study and we found out that this encapsulated follicular variant really lack BRAF mutation, have a lot of RAS mutation like follicular adenoma and carcinoma. While the infiltrative one are different. They can have RAS mutation, but it's different. There are lefts, and they definitely can have BRAF V600E mutations. Next one, please. And finally, I won't bother you with more data. So finally, we did the study at Memorial in 2015, where I was kind of obsessed by the I guess the outcome of this tumor. So I partnered with a colleague from Argentina, and when you compare really encapsulated papillary carcinoma follicular variant non-invasive with follicular adenoma, and the median follow-up between 9 and 12 years, there was absolutely really no recurrence. Next one. So all these molecular and clinical data led to this paper that most of you, if you're interested in thyroid cancer, must know, where a bunch of endocrine pathologists, including Yuri Nikiforov on the call here, Zubair, Peter Sadow, and other, we classified this encapsulated follicular variant papillary non-invasive as a NIFT-P. And next slide, and this will be the final slide. So this tumor will be called today non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Really, I wanted to put this case to show the evolution of the thinking, how we went from using histologic criteria that were not really useful clinically and tipped by the molecular data, we started to better classify this tumor in a more intelligent and practical way for you clinicians. And that's it for me.
Terrific. Dr. Robenshtok, you want to comment on Ronnie's case here?
Yeah, so actually the journey of follicular variant of PTC is very interesting because Ronnie showed the road to NIFT-P, and I think we have a lot of work still left with follicular variant because sometimes it behaves like papillary, sometimes it behaves like follicular cancer, sometimes it's in the middle. For us clinicians, many times it doesn't really matter. So if we have an infiltrative follicular variant, which we did like classic PTC, if we have encapsulated follicular variant, many times we treat it like follicular cancer. So the question moving forward is, what's the difference? What's the added value of follicular variant in other scenarios? Not only NIFT-P, but also in the infiltrative type. And I think it's going to evolve further, like 10 years from now, if we'll have the next session.
Terrific. Well,
Mark, if I may just for 10 seconds, I think the next step, and hopefully it will happen sooner than in 10 years, is to apply molecular classification. For you, I mean, we give you too much. I mean, there is an infiltrative follicular variant, there is encapsulated, with invasion, without invasion. Simply speaking, these tumors can be classified into two groups. They are RAS-like or BRAF-like. And BRAF-like will be given lymph node metastasis and be infiltrative, and RAS-like will always be encapsulated in, if they ever have the patient, at distant sites. That will be much more practical and I think clinically relevant classification.
Yeah, I agree. Terrific.
Any other comments from our panel on this case or this topic?
Just one comment, Mark. When all the pathologists here wrote that NIFT-P, they were very strict about the criteria that had to be met, right? So we saw a case this week that was called NIFT-P outside, and they presented in 3 years with distant metastasis. And of course, on review, it was a high-grade follicular thyroid cancer. So for the clinicians, just make sure when you see that NIFT-P, that the pathologist really has followed. These guys have written very, very strict criteria that needs to be followed. And you can only be reassured if the pathologist has really followed that criteria. So we've seen that a few times over the years. They knew this was going to happen. I remember Yuri and Ronnie having this whole discussion about being really strict, have these criteria. So just a word of caution when you see that, make sure that's been reviewed by somebody that, you know, has followed those rules.
So if that expertise, if you're a clinician, not in an academic medical center, does that case get sent out before you make any final determinations here?
Well, not necessarily. I mean, you know, if I know my pathologist and they've read the paper and they tell me they followed the criteria, I'm good for that. But if I don't know the pathologist and that's been read by somebody else, yeah, absolutely. I mean, it never hurts to have those reread. It makes such a huge management difference, right? If it's NIFT-P, we don't measure thyroid globulins, we don't do intense follow-up. If it's not, the follow-up would be different. So, you know, I think it's just one of that communication. You know, these guys, they've written very strict criteria. If pathologists follow the descriptions and the rules, I think we'd probably be okay.
Right.
I think one other point, Mark, is you were talking about the pathologist. It is very critical to discuss with the pathologist in an encapsulated lesion whether they have studied the entire 360-degree capsule. Because it is not uncommon in many institutions, they will take 3 or 4 sections and say there is nothing. But it is very important to make sure, and that's where the role of another pathologist may come in, who will say, hey, you didn't study the whole capsule. And I think that's very important. The other clinical point is, in thyroid, I think the most important is it an encapsulated lesion or non-encapsulated? I think that makes a difference, whether it is medullary cancer or papillary cancer or follicular cancer. And you can get that information very well on clinical ground, on ultrasound and a CAT scan.
Great. All right. We're going to move on to Dr. Brandwein.
Good morning, everybody. So I got an email that said, yeah, man, we're going to present How Pathologists Think. And I said, dude, do you really want to take the lid off of that box? Do you really want to ask a question and you're not gonna be comfortable with the answer? Okay, next. So then that kind of morphed into the case that taught me the most. Now, when it comes to thyroid, I have to say there's no one single case that taught me the most, because I could think of 5 to 10 right off the bat that are interesting enough to talk about. For me, thyroid is basically a steady diet of humble pie. So there isn't even enough time in our in this to even talk about the runners up that I'm not going to present. But here we go. I'm just going to present the first case that came to mind, but it's just the first of many. So I think that the lesson in this particular case is how surgeons read reports. And here's a 70-year-old lady. She had a history of breast cancer and mastectomy, and she had a history of a hemithyroidectomy for benign disease that Mark told me. Okay, and then she was lost to follow-up, and here she presents with a sternal mass. So let's go over the report. This is from the surgery that was in 2022. So the hemithyroidectomy was on the right side, and so the right thyroid bed was excised. And my diagnosis at that time was recurrent, well-differentiated thyroid carcinoma, at least 1.7. See comment. And there's tissue invasion, lymphatic tumor emboli, soft tissue margins are positive. Now we'll look on the other side. The left side was all benign. And as you can see in part N and of the report, buddy, I didn't say next. Okay. So as we see in part N and other parts of the report, there's this 9-centimeter big old thyroid carcinoma and positive margins, et cetera, et cetera. Okay, and so I said in the comment that it has features of both follicular and papillary thyroid carcinoma. And really, I want to see the original slides. Next. Okay, so I'm just going to show you some pathology from the sternum. And this is the end of, not the end, but this is the stuff that speaks for itself. Okay, this was really looked like a horrible tumor. Next. And so what we see here is just a follicular patterned invasive carcinoma. Next. And so we have thyroid. She has a TERT mutation. Okay, we know what we're dealing with now. But what happened in 2005? Next. Sorry, 2015. So here's the report, which we had right off the bat from 2013. So thyroid right lobe and isthmus, adenomatoid nodule with a nodular cellular proliferative focus. There was prominent, and if you can read the comment here, so this is from the outside pathologist. There was prominent mitotic activity. It wasn't quantified. I think he said, he didn't say, I don't know if it's a he or she, didn't say anything about necrosis, and it was peer reviewed. And of course, was the whole thing put in? Yes, the whole thing was put in 18 slides. So, like I said, I want to see those slides. Next. So, like I said, I want to see those slides. So what do I get? I get a bone marrow core biopsy. So metastatic thyroid carcinoma, and you can see that for yourself. And so I got the hemithyroidectomy slides, but I didn't get all of the slides. And so what I saw, and I don't have any photographs to show you, is in 16 of the 17 slides that I received, it was a multinodular goiter. There was nothing there. There was no necrosis. There was nothing out of the ordinary. In one slide, there was a microscopic focus, which in my particular slide had no necrosis, had no mitotic activity, and it just looked like a hypercellular follicular pattern funny thing, okay? The problem was, but I don't want to make too much of a problem, is that I never got that second slide. So at the end of the day, we kept hocking their Chinik. I want the last slide. I wasn't getting it. And I didn't mean to be in any way aggressive to the pathologist, but I just wanted to see the whole thing. So at the end of the day, in my report, I just said that I could not really issue a report, issue an opinion on this case, the 15 case, because I didn't have all the slides. Okay, next. So in the words of my dear husband, what go on here? You have this horrible massive tumor. You have a history of a hemithyroidectomy, which is called benign, but not really when you look at that report. And I've got most of the slides except for one. And I will trust that that other slide was similar to what I've seen, but had more mitotic activity. But would that microscopic focus really predict the sternal tumor? Well, you know, the first thing that came to mind was this. This is a story that I've been carrying around in my brain for decades. And you can read the story here. This was a young woman who was killed from a brick out of the blue. She was standing in 1979, I believe it was. She was standing on the corner of like Columbia and in the Columbia area in 116th Street and Broadway. A brick fell on her head. She screamed and then she died. And that really impacted me tremendously. I heard many years afterwards, when I just happened to mention that story to somebody, that there was a law that was passed in her honor, to honor her memory. And that's why you see all the scaffolding in New York today, basically because of this girl's legacy. One of the reasons that this story really profoundly impacted me is that I was walking by that place not 30 minutes before this happened. So this was a random thing. You can take that horrible tragedy and basically use it to frame any story of your life next, if you want to. But as a pathologist, I look at that story and I think, could we have caught that falling brick? Is this poor woman, was she going to end up with a terrible cancer? Or is there something we could have done to avoid this? So here's where I want to emphasize how surgeons can be alerted to unusual wording in a report. So I don't know the pathologist. I have no dog in the fight here, as they say. But could the surgeon reading those words, nodular cellular proliferative focus, could some light bulbs have gone off and avoided a 7-year hiatus? From his point of view, he reads the report, he says, oh, it's benign, and we don't know her follow-up. She was lost to follow-up. You know, it's clear she never got any cancer follow-up. So what could the surgeon have done? Could the surgeon have spoken to the pathologist? There's no indication that ever happened. Could the surgeon have prompted an outside opinion? Or could the pathologist have sent this out for outside opinion? I have a feeling that an outside opinion would not have changed anything at that time. But the surgeon might have taken this little tweak to heart and say, well, what go on here? So my best guess is that the primary cancer was left in the bed in 2015. So that what we saw that went to the sternum in 2022 was really an untreated persistence. And it could not have been diagnosed in the 2015 material, but on further discussion might have prompted further workup. And further workup might have found that this was not the whole story.
That's terrific, and thank you for the for putting this into context. I'm going to ask Ashok. Ashok, how often, as a surgeon, do you pick up the phone and call, when you get a final path report, and call Ronnie or one of his colleagues and say, "What do you really mean by that? How do you handle that, and what triggers that?"
I think being a specialized individual taking care of thyroid problems, we do that fairly commonly. And one of the good thing in our institution, and I hope in all the institutions, there is a respect and collegiality amongst pathologists. It doesn't hurt me or doesn't hurt Ronnie if I call and say, hey, this has been reported, this is the MR number, can you please re-review this? And one good thing at Memorial is all the thyroids are, before the pathology report is signed out, they are consulted with Ronnie. So it is written on the pathology report, discussed with Dr. Ghossein, or he saw the slides and he confirmed the diagnosis. That helps me a lot. And it is not uncommon. I would say 50% of the time I'll pick up the phone. I have direct line with Ronnie. And, he doesn't feel uncomfortable when I raise a question that please look at this. When they report vascular invasion, I call him and say, hey, can you re-review and tell me how many areas of vascular invasion? And I think that collegiality understanding is very important to offer the best care of our patients.
Great, terrific. One quick question. Do you have Ronnie's home phone number?
That is only secret with me. That is not to be shared with the rest of the panel.
Excellent. Okay. Yuri, tell us what you learned from this particular case here.
Morning, everyone. Thank you, Mark, for inviting me. Guys, we are having a great discussion from my perspective today because we are hitting on two most common sub-entities or pathological entities that pose very big problem and challenge, not only in the clinical presentation, but also in pathological evaluation. One of them, Zubair described, is anti-arcade fusions. These fusions that are extreme, they are masking as benign lesions clinically and even pathologically. Second scenario is RAS plus TER. Margaret case is a great case. You see, this is RAS, but my guess is that most of that thyroid was RAS TER tumor that masks as benign goiter. This is a model. We see these cases, maybe almost every month, every 2 months, and pathologists always get puzzled. How can it be metastatic cancer? It looks so benign. So this is a case also that will illustrate that. So this is a 57-year-old patient who presented in 2014 with thyroid nodule and some hemoptysis and hoarseness. Core biopsy was performed. And you see core biopsy. I have here 4 pathologists who, spend their life looking at microscope, correct? If you look at this core biopsy, it's goiter. It's huge, very large follicles, variable size, even a low power thin layer of epithelial cells. Next slide, please. I think I have, this is a higher power. People would not even call it adenoma. People will say this is just benign goiter, benign hyperplasia. Next slide, please. This is the highest power. Would any of you guys call it nuclear features of PTC? There is slightly clearing, but there is a clumped chromatin. Really, there is nothing here. So next slide. So pathological diagnosis was benign thyroid tissue with abundant colloid. Nothing was done with the patient. Next slide, please. And 3 years later, in 2017, patient presented with repeated episodes of hemoptysis and mild hoarseness. CT scan, 3.5 cm soft tissue mass involving trachea. FNA performed, again, benign thyroid tissue, no evidence of malignancy. But because of the clinical presentation, they sent it for molecular testing. It came back as positive for NRAS mutation. If nodule has clonal mutation, it is 100% tumor. This is something that still we need to sort of to educate our colleagues in the field. It's not any longer hyperplasia. It can be benign, yes, can be benign, but this is tumor. We are not any longer talking about hyperplasia, goiter, or something like that. Next slide, please. So basically, based on now with the old clinical symptoms plus the knowing this is a tumor, total thyroidectomy was performed with anterior tracheal excision. And this is again the tumor. Again, my fellow pathologists, you look at this and look at the slides, what you would say? You would say that this is what? This is goiter. This is not even an adenoma. There are some areas little bit follicles a little bit smaller, some larger, and only in scattered areas in this mass, scattered areas, you can see on the right, you start to see maybe some nuclear overlapping, maybe some clearing of chromatin. Next slide. This is a high power. I cannot say that these are overwhelming nuclear features of PTC, but you start seeing sort of something that the nuclear features of PTC is present here. Next slide. And this is something that gives it away. You see it invade trachea, you see invading the respiratory mucosa and basically encasing tracheal cartilage. So the final pass diagnosis is follicular variant PTC with tracheal invasion. So again, I want to say that we are discussing today two entities that in the past people called, if you read the literature 50, 70 years ago, benign metastasizing goiter. You know, maybe we are laughing now at this, but this is how it looks so benign that people have hard time to believe that these are actually tumors. Okay, but these are tumors that and again, I mean, NTRK3 tumors behave a little bit differently because they will give local lymph nodes metastasis and distant. RAS-like, I mean, RAS plus TER, they will never present on the neck, almost never, unless this is just by direct extension, as in this case. Either they locally invade or they give distant mets and present in sternum, in bones, and any other. So that next slide, please. That really case, you know, teach me again sort of humility, understanding that even looking at thyroids for all our lives, sometimes it is very, very difficult without ancillary methodologies and ancillary data to really arrive to the correct diagnosis. Thank you.
Terrific. Michael, do you want to comment on this?
Yeah, I mean, this is really cutting edge. I mean, we're getting to that point where what's the gold standard for cancer, right? Is the gold standard what we see on the pathology slides, or is the molecular testing beginning to supplant that? Because we've seen with Yuri some cases that were clearly cancer, behaving like cancer, but you stare at the slides and they just haven't developed those sort of histologic features, because in the natural history, they have to get the molecular changes before they demonstrate the histologic changes. So there are some of those situations where we're going to be like right on that cutting edge. So I think, you know, we're used to that in parathyroid cancer, right? We're used to that in FEO, that what they look like doesn't always predict that they're going to be a cancer. And some of these follicular variants, to my mind, are kind of living in that same area where some of these are clearly going to be a molecular cancer. They're going to behave as a cancer, but yet they haven't gotten that sort of complete histologic feature. Maybe like Yuri did, you can hunt around and find a few areas that are a little bit worrisome. But I think we're looking right at that cutting edge, that they didn't become a cancer when they invaded the capsule. They were a cancer that invaded the capsule. And so that area is where it's, you know, something we need to think about. Have to be careful. You don't want to call benign tumors cancer, but we have to recognize that interface exists. And when we have these really high risk molecular features, we're just going to have to recognize that's a cancer. It just hasn't totally demonstrated the histologic features of it yet. So at least, Yuri, that's how I'm kind of thinking about this. Is that the way you're sort of thinking about it from you're looking through the microscope?
You see, absolutely. I can tell you, I mean, it's a little bit drives me crazy. You know, we give sometimes in the needle diagnosis RAS and TERT, RAS, TERT, EIF1AX. And then I got a call from a clinician 3 weeks later and say, we removed thyroid and there is nothing there. And this word nothing drives me crazy. What do you mean nothing? Oh, you know what? Pathology says that it's just a lot of colloid. There is really nothing. They probably did surgery for no reason. And this is not the case. And again, I mean, we have to sort of take a next step in and understand that this is not surgery done for nothing. This surgery was really very important for this patient, because otherwise 3 years later, I mean, he or she would be presented with sternum mass, and we were, I mean, pulling our hair where it came from.
Yeah. I want to make a comment. So I was actually expecting, when I saw, you know, when I was looking at the original material, I was expecting to see, Yuri, what you are demonstrating is something unusual percolating through what looks like an adenomatoid nodule. So I want to make clear what I saw was not that. And so what I saw was one of two foci, and I thought, well, how could that have, how could that have recurred? It was more likely in this case, it was never taken out. But
yeah, of course, not seeing the case, you may be absolutely 100% right, but I can tell you, the only way to be sure now is pull out that case and just map it molecularly and see, and I bet we probably will find that nodule that was extremely indolent that gave this distant match. And if we don't, that means that it was left behind, like you said. Yeah.
Terrific.
I'd
All
like
right.
to add something.
Yes.
Because even the molecular markers in the RAS type tumors don't always give us the answers. So I'd like to mention some other tools that we sometimes use in clinical practice, like PET-CT. Sometimes, for example, if we have a lateral mass in the neck and it's inconclusive, if there's significant uptake on PET-CT, it can drive us for surgery. And sometimes that we do, Dr. Hirsch in my hospital did a study about it. If a large follicular type tumor is taken out and is called benign, we always check for thyroglobulin after surgery.
Right.
Just to make sure it's not in the thousands. And just something else that like safeguard not to miss these cases.
Right, that's a great point.
All right. We have to get to the person who has the final word here. And I think this discussion has been a terrific segue into Peter's case here. Peter, you're up.
Yeah, I was left last because I knew I could be clipped. But in any event, this is a case actually that's just from a week ago. And the reason I actually had it photographed was because much like many of you, our surgeons basically say, oh, would you photograph this case for me because we need to present it at a conference, and of course you're not doing anything else, so would you mind doing that? So this is what happens. But it turns out the question that was asked of us was a case that taught us the most, and every single case teaches me the most. So the fact that this is a week ago means nothing because I learned from all of them. So the important point here is a 39-year-old woman. I want to point out briefly, Yuri's case that he just showed, he absolutely hit the nail on the head with every point out of his mouth. It looked benign. I wouldn't care about it. It was a goiter. It was nothing other than the fact that his headline was patient presents with hemoptysis and a hoarse voice. Something about that case did not fit the clinical picture. And so the idea of what you're looking at the microscope, it has to be taken in the context of what is the situation you're dealing with, which is what you have here. Next slide. So this patient had a prior right thyroid lobectomy in 2019 for a multinodular thyroid disease, which was called benign. She's had a completion for this enlarging dominant nodule. She's currently pregnant. And the initial diagnosis of the dominant nodule, this was done in upstate New York, was poorly differentiated thyroid carcinoma. I say that it's fairly important because unlike the whole discussion that we're moving toward a molecular diagnosis, this patient never actually had any molecular testing on this larger nodule, despite the fact that she's pregnant. And so next slide. This is what the thyroid looked like. I try to show it on low enough power that you can see in these that it's multinodular. So there are different thyroid nodules that are present in this lobe. One thing to notice in the bottom right is that you see ink on the far right of the slide, and this is actually ink on tumor. And one of the things that happened in this particular case is maybe the way the clamp was placed in the surgery, but the thyroid came actually open. So the nodule was actually disrupted. To make a comment about its circumscription would be impossible given the fact that we can't see the whole thing. So next slide. This is what the nodule looks like. It's quite solid growth. This is low power magnification, and higher power you can see the somewhat insular growth pattern of this tumor. Next slide. So you can actually see this bit of edema between part of the nodule and adjacent nodule on the left. This is what that box is around, but it's still within the confines of the lesion proper. The nodule itself was not encapsulated, but well circumscribed. And then if you start looking closely, you can start finding discrete mitotic figures. Next slide. So the final diagnosis that we had here that I made was a thyroid follicular nodular disease with a dominant atypical solid adenomatous nodule, 2.1 centimeters by report. Now, there were conspicuous mitotic figures. There was no necrosis. There was no observed invasion, either capsular or vascular. But if this was an invasive tumor, this would have been evaluable as poorly differentiated thyroid carcinoma. And so here we're talking about the diagnosis being either benign or a high-grade malignancy. I mean, this is one of the challenges we're left with. Next slide. So the criteria for poorly differentiated thyroid carcinoma are solid trabecular insular pattern of growth, which we have here. But the diagnosis of malignancy is based upon invasive properties, and we did not have invasion seen in this nodule of a multinodular thyroid. Absence of conventional nuclear features of papillary thyroid carcinoma, which we did not have those features here, and at least one of the following: convoluted nuclei, mitotic count greater than or equal to 3 per 2 square millimeters, which we have here, or tumor necrosis, which we don't have here, but we have no invasion, and therefore we can't call this poorly differentiated carcinoma. Next slide. However, it's really difficult because am I sure it's not poorly differentiated thyroid carcinoma? The answer is no. I'm not sure because we don't have all the information. We're not able to see the entire circumscription of the lesion given the fact that the tumor is disrupted. We see mitotic figures, but we don't see any necrosis. We don't see any invasion. The entire tumor is submitted. Levels were performed on all of the blocks. But what do we need here? We absolutely 100% need molecular testing on this particular nodule. The patient's pregnant. They're aware of this. They're aware of this. The clinical team is aware of the discrepancy in the findings. They're aware of the possibilities in this tumor. So now we're going to have molecular testing ordered on this patient in this case. So you know, this is really subjective but monumental in terms of the significance. Caveats in this case about this disruptive surface and inability to evaluate the entirety of the tumor periphery are needed, and follow up given the presence of this. There's an actual residual nodule present in this patient. They didn't get the entire thyroid tissue out. There's a nodule in the bed that's 1.4 centimeters that they're aware of. But this is not enough to prove that this is poorly differentiated carcinoma. It's enough to prove that, you know, maybe the surgery was incomplete or something happened during the surgery. So now they're aware of the nodule that's present. They're aware of the risks of malignancy for this patient. And now molecular testing needs to be done on this tumor along with follow-up, but at the same time, giving this patient this grave diagnosis without actually having the proof. But the close line between really bad malignancy and benign is really difficult in this case. So I thought this would be kind of a nice case. And I think one of the things that we've noticed as a theme throughout everybody's presentations are we're really having difficulties with these tumors of uncertain biological potential. Some of them look very benign, some of them look very horrible, but it's unclear what the biological potential of these lesions are. And that's the part where, as pathologists, we're really at that line where molecular diagnostics are exceptionally helpful, but it all falls into the clinical context of the case. That's it for me.
So, Peter, thank you. I'm going to ask you, as a pathologist, what direction, when you're sitting on the fence in a situation like this, where do you tend to lean? Where do your instincts take you, medical legally? Where does it take you? How do you put all of those competing influences into your final pathology report here?
Well, I think overt honesty is the way that I typically handle it. When I don't know, my note describes that I don't know. And I actually give both sides of the picture in terms of I cannot see any overt features of malignancy here. However, given the following features, I'm concerned, and this is what I recommend that you do. I recommend molecular testing. I recommend following up. I recommend the fact that we can't see the entire periphery is a poor feature. So these are the types of things that we need to do, and these are the caveats. Now you need to take these caveats and do what you're going to do with them. But I don't call something overtly malignant if it's not, simply to cover myself. I think that's really a disservice to the patient, who deserves honesty. And the honesty is, we don't know. If we don't know, we say we don't know. But these are the things that we need to follow up. And these are the things we can do to be as sure as possible.
Those are terrific lessons, terrific conclusions. Obviously, from a patient's perspective, to hear that is very, very difficult. And so, as always, Mike, I'm going to give you the very last word here. Do you want to comment on Peter's case?
Yeah, I think it's a great case. And the reason we're all uncomfortable is I don't think any of us know the natural history of this disease, either treated or untreated. Part of the reason we're so confident is we know these patterns. We know what happens in these things. And in this case, I have no idea what the natural history of this disease is. So I would tell her that. I would also tell her, I don't care what this is labeled. I'm going to follow you and we'll figure this out over the next year or 2 or 3. So I think having that note from Peter that says, here's the description, I'm not sure where this lives, it helps me open that conversation. And I think cases like these need to be seen at specialty places, because if this group of people here don't understand the natural history of this disease,
Right.
I suspect
Right.
most people don't.
Right, right.
Perfect. I want to thank everyone. Peter accused me in one of the emails that this would turn into a docudrama. It didn't quite get there. This was incredibly informative. I've got another 10 questions that I wanted to ask the panel. As everyone predicted, we didn't get there. And so we will call you back and call upon you again. This was truly a spectacular session. I want to thank everybody, thank our listeners, and very much hope that you will join us again next week. Thanks, everybody. Peter, have a great vacation.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.